Hey guys, can you hear me?
Hey, Miss Silk, I can hear you.
Okay, perfect. All right, give me 1 second. I'm just going to open up a couple of things so I could share with you guys.
So can I mention one thing before we get started?
Yeah.
In the announcement, you mentioned we'll go over exam 3. Did you mean exam 2?
No, I do mean exam 3 because I still have to go over some new material with you guys to get you ready for that.
Okay.
Now, my plan is Tuesday when we meet, that's when we're going to review for exam 2.
Okay, understood. I feel better.
That way it'll be like fresh in your mind for Thursday. Make sense?
Yes, it does. Thank you.
Okay. I appreciate you guys coming on. I know this isn't a normal time that we meet. It was just kind of a crazy morning with all those tests.
So I'm not going to lie, I like how we get the grade right away.
Yeah, that's kind of nice. They didn't put the tests on there the correct way though. So I'm not sure what our next one's going to look like. It might look slightly different, but you'll be able to see what you get right away and everything still. Geez, everything is going so slow on here.
This is Silk.
Yeah.
Whenever we're logging on, like to get into for our exam, can we just kind of make note that there's other people still taking tests? I know that it's all new and everything, and I totally get it. It was just, I had a really hard, me personally, I had a hard time because it was very distracting.
Yeah, I understand that. So it just was kind of a cluster today because I tried to split you guys all up, but then even by doing that in a smaller group, people were still all like taking too much time getting onto Land School Air and, taking more time than what they should have taken for their test. So it just was a cluster. So we'll have it better for next time, I promise.
Okay.
All right, I'm just opening up a couple PowerPoints here so I can go over some things if I can get this to cooperate here. All right, so what I want to do first is I want to go over a little bit about bariatric surgery with you guys.
Can you tell me what PowerPoint you're on, please?
Hey, why am I hearing myself? Hold on 1 second.
Okay.
Miss Silk, it's saying you have low signal, low Wi-Fi. Like it says your Wi-Fi is in the red.
Oh, I'm listening to my. I must have hit my recording here. I didn't mean to do that. Okay, let me get back to where I was at. What are you guys seeing on your screen right now?
I'm seeing your PowerPoint, patients with gastric and duodenal disorders.
I am too.
Okay, perfect, good. I just want to make sure I had the right thing up. Okay, so I am going to go down to where we would have talked about bariatric surgeries and we'll kind of go from there. See if I can find it. Here we go. Okay. So in the one chapter that we have in our big book, it's all about like obesity and bariatric surgeries and stuff. It is, let's see. Try to see what exact. It's like chapter 48. So out of that chapter on test 3, we're going to have a few questions out of this. So some just basics about obesity. So we know that you're going to be considered obese if you have a BMI of 25 to 29. So you also are considered obese if you're greater than that, right? So if you have a BMI greater than 30, and then morbidly obese would be a BMI greater than 40. So you will see when people need bariatric surgery, it doesn't necessarily mean that they're going to be a BMI of 40 or more. Oh my gosh, I keep hearing my... Gee whiz, all this stuff keeps popping up that I don't want. Sorry about that. Okay, so anyway, so what I was trying to say is people who end up having bariatric surgery, they're all shapes and sizes. So you are not necessarily going to see someone who's really, really big every time that wants bariatric surgery. It could be someone who's a lot smaller that maybe you wouldn't really think they would need it. So that's not the only criteria for getting it. But anyway, other than talking about BMI and everything in this chapter, it talks about some just basics about obesity. So patients who are obese are at risk for all kinds of other problems, just like we're all aware of. So, you could be more at risk for hypertension and diabetes and stroke and all those kinds of things. So it's always better to try and lose weight to make yourself, not have those risks anymore, right? So what do we usually tell people to do first when we want them to lose weight?
Tell them to lose weight? I'm just kidding.
Yeah.
Yeah, but what do we tell them to do?
Eat better?
Exercise.
Eat better, okay. What else?
Exercise?
Exercise, yes. So things that they can do themselves. So we try to get them to change their eating habits and then also to be more active, right? So that's something that's really important to remember out of this chapter. So you always would rather them do those things first than just jump right to taking some kind of obesity pill or, do some type of, invasive surgery like bariatric surgery. You'd rather them try those things first. The other thing this chapter kind of gets into is that, we have such a huge population of people who are inactive and that eat bad, but there's a lot of reasons for that. A lot of it is because of socioeconomic status. So this means that, it's easier to eat bad than it is to eat good because it costs a lot more to eat good. So when you go to the store and you're at the grocery store, when you try to get those things that are better for you, they're more expensive. And then plus it takes a while, like to really do things the right way and to do it well, you need to actually take some time and plan out your meals and like spend some time making a good meal instead of doing everything really quick that like we all want to have done. Okay, on this slide, it talks about a couple of medications that the chapter mentions that are for obesity. So unfortunately, usually people will try diets and they won't be really successful with them because of one reason or another. So then they automatically want to reach for some kind of magic pill to help them lose weight. So there are multiple different types of pills out there that I'm sure you've all seen before at the store or heard about on a commercial or whatever. But one that I really want you to pay attention to is Orlistat. Orlistat is a medication that if you decided to take this, you have to take it every time that you eat, but only when you eat things with fat in them. So this means like if I eat breakfast and I don't eat anything with fat in it, then I shouldn't be taking Orlistat. So the thing with this is, my understanding is the way that it works is it kind of binds with the fat in your foods so that you don't absorb as much of it. So some of the weird things that you see associated with it, then when you take it, you have like lots of gas, you have like oily looking stools and like weird stuff like that. So there's a lot of crazy side effects from it, and usually people don't really like it because of that. So definitely know that medication. Make sure you look into that in depth. This also mentions a couple other meds on here. You know, this Belviq is one that's kind of popular. But anyway, another thing that the chapter says is that some of these drugs have been pulled from the market because of increased risk of suicidal ideation. So a lot of these drugs, you know, no matter which kind of, you know, weight loss drug it is, it's going to have side effects. And most of the side effects are not good. So this is not like a magic pill to help you, really. So generally, the medications don't work really well. Okay, so then it gets into the bariatric surgeries. So this is a surgery for obesity that's only performed after other things were attempted first. So this means if you say, okay, I want to have bariatric surgery, and you go to your physician and ask for it, your physician's going to say, okay, well, what have you tried first? They usually want you to have gone to some type of, you know, physician weight loss place like Weight Watchers or Jenny Craig or something like that, or Physicians Weight Loss, you know, something along those lines where you have actually tried and given it a good try for so many months, and then maybe it just didn't work or something, or maybe it did work for a little bit, but you didn't lose as much as you wanted. So you have to have that documented that you've done that first. The other things that this mentions, most insurance companies will only authorize bariatric surgery after a patient who is obese tries for 6 to 18 months doing a diet like that. So it has to be like a long period of time that you've tried. The surgery may be performed laparoscopic or by open technique. Typically, you're going to see laparoscopic more than open. You know, generally that's what we do most of the time. So the only time really that it would be converted to open is if they had problems when they went in laparoscopically at first. The two most common procedures would be Roux-en-Y and sleeve gastrectomy, and we'll talk about those a little bit more here in a second. Other procedures that the chapter mentions are gastric banding, vertical banded gastroscopy, or I can't talk, gastroplasty, and biliopancreatic diversion with duodenal switch. So those are a couple of the other ones that it mentions. Now, I do want to say in this chapter that I mentioned, there is, which I forget what page it's on, but there's a certain box that it talks about, let me see if I have it written down somewhere. It talks about the criteria for bariatric surgery. So I would definitely take a look at that.
I have my book. Is it 48-1?
Here it is. It's on page 1369 in your book. It's a chart that's called Selection Criteria for Bariatric Surgery. So the other things with that, you know, being able to be approved to have bariatric surgery would be not only do you have to have tried some type of diet for that period of time, you also have to have, you know, a BMI that's kind of bad. And then you also have to have some disorders, like maybe I have diabetes or I have hypertension or something along those lines that are kind of out of control that you really want to get fixed, those types of criteria. And then usually they're going to make you do some kind of psych eval as well. So the psych eval is to make sure that you are able to make good decisions about the surgery. They want to know that after you get this done, that you're not going to just go off and do whatever you want with, you know, eating, that you're going to follow the directions with what you're supposed to be doing to eat. Does that make sense?
Makes sense to me.
Yes, no? No one's commenting. Okay. Thank you, Ashley, for the thumbs up. Okay, so here is where we get into the different types of bariatric surgery. So Roux-en-Y, this is the one that you see most of the time. So this is going to create a pouch that holds about 20 to 30 milliliters of stomach contents. So basically in this picture, I don't know if you could see the dotted lines like right in here, but they take away the majority of the stomach and make the remaining stomach super small. So it's almost like the size of a fist in a way. If you like hold up your fist, it's very small. It only will hold 20 to 30 cc's. And then they have to reanastomose everything to reattach everything so, you know, your GI system is working like it should. So it's kind of a big deal, this surgery. When you have this done, like I said, usually it's laparoscopic, so you're going to have about 6 different lap sites over your abdomen. Typically, if you have this surgery, you'd have it one day, you would be in the hospital the following day, and then the next day after that is when you would go home. This type of surgery is what they call, what am I trying to say? This is like a surgery that is going to affect how everything is absorbed. So like you can imagine, would we say about the stomach, you know, the stomach has lots of gastric acid and stuff, and it breaks things down so that you have easily absorbable parts, right? So after, you know, you make this really a lot smaller and you reattach it to the intestines, things aren't going to absorb as good as they did before. So you're going to have issues with that. So after this surgery, for the rest of their lives, they're going to have to take lots of different supplements, lots of different types of vitamins and stuff for the rest of their life. So if you were their physician and you were watching their labs are always going to be out of whack. And that's why. This surgery generally will work really well. People lose a ton of weight from this, and it's not an easy thing to go through, but if you have the right motivation and the right people around you, you can do it, and it really is a good thing. Now, if you were someone who was obese and you decided to have this done and you did really well with everything you were supposed to do, you could essentially possibly even get rid of your diabetes from this. If you started out as a type 2 diabetic and then did really well, this could totally help you get rid of that altogether. I did mention the gastric banding a little bit here because occasionally you'll still see a patient here or there that might have had this done. This is something that SUMA does not do anymore. When we started doing these years ago, they did do these, but then over the years, they started to see that a lot of people were having complications from them. And so they didn't think it was very safe anymore, so they decided not to do them. What happens with this is they have this band that they put around the stomach. And this band has like a, I don't know what you call it, like a lumen or it's not really a string, but like tubing, I guess, that goes to it. So you can actually inflate or deflate that band. So if you inflate it, it's going to make it tighter. If you deflate it, it'll make it looser. So your physician, every time you would go into the office, they would have the ability to tighten that or loosen it if they thought you needed it. So this is kind of what we call a restrictive type of a surgery. So it's restricting because it restricts how much that you can eat at one time. So if that band is around there, you're not going to be able to fit as much in your stomach. You're going to feel full a lot quicker. And so it restricts how much you eat, and that's why you would be losing weight from this. So the problem with this surgery is that that band was slipping. So many times when we used to see people come in with issues with this, the band would have slipped and migrated somewhere else in the body where it shouldn't have gone. And so then it causes bigger problems. So that's why they don't do that one anymore. But anyway, this one, when you did this, that band, it would restrict you so much that you could only hold about 10 to 15 cc's in your stomach. So super small. Okay, the gastric sleeve. This is another one that's really popular right now. SUMA does quite a few of these as well. So you saw with the Roux-en-Y how they totally make the stomach really small and get rid of like the majority of the stomach. This like totally gets rid of a lot of the stomach, but it makes it like a long, straight kind of a thing, like a sleeve. So you still have like sutures or staples there to like, staple that up. But generally you can, it's not as much of a problem with absorption and stuff as it would be with the Roux-en-Y because of just what they take away. So you still have a little bit of your stomach there. All right, so this surgery, a lot of times it's done for people who are really large. Like if I wanted a surgery, a bariatric surgery, and say I'm 600 pounds. If I'm 600 pounds, I'm not a good surgical candidate usually. However, they would rather do this surgery than they would the other surgery on me first because this is going to help me lose a little bit of weight. And then once I get down to a safer weight, then they can take me back to do the more complicated Roux-en-Y. So this one, 85% of the stomach is removed and it leaves that sleeve-shaped area, like I said. Everything else kind of stays intact. So it decreases the size of your gastric outlet. So again, you're not going to eat as much because of just the difference in the size of the stomach. All right, and then the last one, our chapter mentions this biliopancreatic diversion with duodenal switch. This is a crazy surgery. So what they do with this one, they remove half of the stomach and they leave a small area that holds only about 60 cc's. And they have to reattach everything in a crazy way. So this is talking about this duodenal switch. Like you would have to reattach everything totally different than it normally would be. So that would be another option for someone if they wanted that surgery. Okay, so the other big things that I want you to focus on with bariatric surgeries, you need to make sure that your patient follows their dietary restrictions. So I'm going to kind of tell you what it's like to take care of someone like this. So typically, if you were on the surgical unit that was getting a surgery like this, you would get the patient from recovery room to your floor, and usually they're going to be all in pain when they first come to you, and they're going to say their pain's a 10 out of 10 and they want pain medicine right off the bat. So of course you would do that, but you want to make sure that they're all set when you first get them. So a lot of times they still have a lot of anesthesia in them and they need to kind of sleep a little bit of that off. So you would hook them up to the heart monitor. You would, if they came with a Foley, you would hook the Foley up on the side of the bed, see how much they were putting out. These guys always will come with a drain. So usually they'll have a Jackson Pratt drain that you have to check. So that will be coming out of one of their laparoscopic incisions. And then they also come with something called a on-cue pain ball. So the on-cue pain ball is another way that they can help treat their pain. However, just having that by itself is not enough. So typically you have to do more than one thing. So the on-cue pain ball is filled with a type of medicine that's like a lidocaine, like something along those lines. So this medicine will infuse into one of their incisions, and it typically does that on its own without you having to do anything. And it just kind of helps numb up the area a little bit. So they have that, so you'll have to be looking at that. Usually they come to you with a binder on, an abdominal binder. So you would have to open up that binder to check out all of their incisions to make sure everything looked okay. All of their lap sites will have steri strips on them. So typically you're going to look at these steri strips and make sure they're intact, that they're not bleeding a ton from any site or anything like that. The other things that you're going to do, so they're going to come to you with IV fluids running. So you always want to make sure that you have the right IV fluids running, because many times when you get someone from recovery room, what they have running when they get to you is not what is currently ordered on your unit. So then you may have to change to something else. So that first day of surgery, they're going to be running their IV fluids kind of fast. So typically maybe 125 cc's an hour. And this is on purpose because that first day of surgery, they're going to be nothing by mouth the whole day. So they need, all the fluids they can get. So anyway, after you get them all checked out, you do your assessment, you make sure everything's going okay, you medicate them for pain, then they are going to rest for a little bit to try and get rid of some of that anesthesia, and then you're going to get them up. That first day, they want you to get them up to the chair and also to take a walk with them in the hallway. If your patient refuses to do this for one reason or another, then you need to call the physician. They want to know. So that's what you're expected that first day. The second day, when they get up in the morning, they are supposed to go down for an upper GI. And I don't know if you remember us talking about the upper GI, but that is supposed to be to check to see if they have any kind of leaks. So remember, we said they do these anastomosis sites. So, you know, they make the stomach a lot smaller and then they reattach everything, right? So those spots where they reattach are called anastomosis sites. So of course they would have sutures or staples to, you know, connect all of that back together. So those sites, you know, this person would get some kind of barium that they would have to drink. And during the upper GI, they watch as all that barium goes down through and they see if there's anything that leaks. If nothing leaks and everything looks good, then when they come back up to your unit, then they're allowed to have liquids finally. So typically everyone's thrilled once they know they can actually drink something again, even though it's just little bits. If they don't pass that, then they're going to remain NPO and they're probably going to start them on TPN so that they can get some nutrition in the meantime. The anastomosis sites, typically they don't, you know, leak a ton. If they did leak a little bit, then you would just keep them NPO, and usually that would close up in a few days without you having to take them back to surgery to really do a whole lot of work. Now, if it was a big leak, that's a different story. Then they would take them into surgery and fix it. Okay, so anyway, that second day, after that, they come back from that upper GI. They're allowed to drink. They're on a bariatric clear liquid diet. This means that they can only have certain things. They are not allowed to have anything with carbonation. So carbonation, like, just like I think we mentioned this before when we talked about GERD and stuff, when you have stuff with carbonation, it actually expands in your stomach and it's not good for you. So it can cause you to have bigger issues. So they do not want to have anything with carbonation. They are not allowed to use straws. And they can't have anything real sugary at all. So everything has to be pretty bland. So on their trays, they'll get 3 trays during the day. They'll get a breakfast, lunch, and dinner tray, and it'll last them for hours because they're only allowed to take little bits at a time. So on their trays, you usually will see hot water for tea. You'll usually see a lemon ice, because those lemon ices usually don't have a lot of sugar. It's usually pretty bland like. They will have a high protein broth. So it's not a soup, it's like a broth, and it has more protein in it. So it's good for them to have some of that. I'm trying to think what else. I think there's one other thing I'm forgetting, but I can't remember what it is at the moment. But anyway, there's just a few different things that they can have. So that's what they're going to be picking at the rest of the day. So whenever they get a new tray, you could like switch out for the old one and stuff. So that day, that second day, they are allowed to have 30 cc's every half hour. So at SUMA, what they do is they give them a paper and it has like a bunch of times on it, and they can mark off when they had their last drink so they can keep track. And then it's kind of nice because then you as the nurse can just go look at their paper and see how much they had and add up your I&O for the shift. So that is part of that. So every half hour they can take these drinks. Now, when you come in as the nurse to give them medicines, how is that different? So this means, like, say I have to take 4 or 5 medicines at a time, like a lot of people do. These guys can't do that. They can only take 2 or 3 meds at a time. So if this person did take 5 or 6 meds, then you would have to split them up and then come back a little bit later to give them the other ones. Just because of how everything is put together differently and how they digest everything, it's not good to give them a bunch of things all at once. Now, you generally don't have to have things cut up or anything like that. They usually can swallow things whole. although sometimes people will complain that they have swallowing issues. So, you know, like say you give them a Percocet and they feel like it's stuck, they can take as much as they need to get that to go down. That's not going against any of their, you know, things that they're supposed to be doing. Okay, so again, that second day, they're going to start their eating and drinking, and then they are expected to be up in the chair at least 3 times that day, and then also to walk numerous times. The walking is good. It's always good after any type of abdominal surgery, because usually you feel like you have a lot of gas in your stomach from some of those types of surgeries, and that's the only thing that's going to get rid of that is you walking around. It helps that move around. So some of the other things on this slide that it's talking about as far as like stuff that we would be keeping track of when we take care of a bariatric patient. Now, we talked about their pain. So the next day for pain, usually after they have passed that upper GI test, they're able to take things by mouth. So usually it'll be like a Percocet or something along those lines that they can have for pain. That second day, you know how I said they had IV fluids. So the IV fluids will be turned down. So instead of going at 125 an hour, they're either going to go at 100 an hour or maybe even 75 an hour for the rest of the time they're in the hospital. Because now they're able to drink a little bit so they can make up for some of that fluid loss. We want to prevent infection and anastomotic leak. So again, we're going to be watching those incision sites, making sure everything looks okay. With their drain, we want to change that dressing every day and make sure that looks all right. With the drain, we don't want to see a ton of stuff coming out of that every time we look at it. We only want to see little bits in there. So if you're putting out a lot, that's something you need to call about. Other things, a lot of times people will be like, oh, can I step on the scale the very next day after they had the surgery, thinking that they're going to be, you know, less weight the next day. You don't see, you know, stuff that quickly. So that's something you just need to talk to them about. And then it talks about maintaining bowel habits. So, you know how we said that they go for that upper GI. So when they come back, remember when we talked about upper GIs, we said because you're taking in all that barium, you need to get rid of it somehow, right? And it's going to come out through your bowels usually. So when they do have a bowel movement, it may look white and chalky. So we need to make sure they know that. And then also, bariatric patients in particular sometimes will have bloody bowel movements. So if this is the case, if their first one after their upper GI, they have a bloody bowel movement, you need to see it. So you need to make sure you take a look in the toilet and see if it's really like super bloody or just like a dark blood or if it's bright red or what. So typically you're going to call about that, and then your physician will probably say, okay, let's draw some blood work. Let's get an H&H. So they would draw their blood and they would see what their H&H was. And if it was pretty low, then maybe they would transfuse a unit of blood or something. But then generally that's all you're going to do. Now, if it was a big time bleed, that's another story. You know, you're going to see your H&H really drop, and you may have to give them boluses of IV fluid and everything just to get their blood pressure to be okay. So it kind of varies depending on the person, but typically that's not something you see with everyone, but it's not uncommon to see that happen. So you always just try to remain calm when you see that it happens so that you don't freak them out, and because that is, you know, upsetting for them to see. And just tell them that you're going to take care of it the best way that you can. Okay, here's some complications after bariatric surgery that people can have. So we just talked about hemorrhage. So typically when you see the hemorrhage, it's usually going to be in their bowel movements. That's usually what you'll see most of the time. Bile reflux. This is something that sometimes people will have. So just like GERD in a way, you know, that's kind of what this is, except it's more bile that they'd be getting up than GERD, than, you know, like your regular gastric secretions or whatever. So dumping syndrome, which we all talked about in our discussion post this week. And dumping syndrome is not something that everyone will get. It's not inevitable that you get it. As long as you follow your dietary restrictions, you usually are okay. But if you do get it, sometimes it's because you're not following what you're supposed to be doing. So you need to fix that, you know, so that's something you need to address with them if that's the case. And then another thing I wanted to make sure you guys are all aware of is that this can be self-limiting. This means that if I have dumping syndrome, it can fix itself over time sometimes if it's not too bad. Now, in that article, it talked about some people who have it a lot worse, and then that's different. You know, then they would have to do other things for that. But generally, it's pretty, you know, mild when people have it, and then, you know, it can end up fixing itself. Dysphagia is another thing that sometimes they'll say that they have. So you generally need to tell them to kind of slow down as they're eating. And it's weird because when they eat, usually we don't want them to drink when they eat because they can only take in those little bits at a time. So we tell them to eat, and then maybe when they're done eating later, take some drinks. So the dysphagia is kind of something they just need to get used to the different ways that they have to eat now, and then usually that gets better. And then bowel or gastric outlet obstruction. So remember what we talked about with gastric outlet obstruction. So if that outlet is too small, usually you're going to have some different symptoms. So in the bariatric patient, do you guys think that you would be able to drop an NG for a bariatric patient?
No.
Someone say something, answer.
No. Can you hear me?
No.
Teresa, can you hear me?
I can hear you, Ashley.
Okay, so
I'm
she
not
can't
hearing
hear any of
anyone.
us.
I can hear you guys, but I don't think that she can hear you.
She can't hear us. We gotta.
All right, so generally with the gastric outlet obstruction, your thing would be, hey, I'm going to put an NG in. However, with a bariatric surgery patient, you would never do that. So if you had a resident that came around and wrote for you to do that, you would always question that order. And the reason for this is because think about it, when you put down an NG tube in someone, you're going down into their stomach. And now we have a stomach that's a lot smaller than we normally would. So how are you going to know that you're in the right spot? You could easily screw something up by doing that. So never put an NG in for that. Okay, you guys are saying you can hear each other, but I can't hear you for some reason.
Can you hear me? I
And
can hear you.
you can all hear me though?
Yeah, I can hear you.
I can hear you, but
Okay,
you
as
can't
long
hear
as you
me.
can hear me, that's good. All right, I don't know what the deal is. I'll just keep talking, I guess. Okay, so those are the big things about bariatric surgery that I want you to know. So again, for your test, it's going to be some simple things about obesity itself, and then some specifics about bariatric surgery. So just kind of look at those things. Again, you know, those things that I told you on that one page, you know, about criteria for bariatric surgery, that would be really good to look at. Okay, so let me stop sharing this a minute because we're done with that. Okay, I don't know why I don't have that, or maybe it's in here. Let me look somewhere else. Yeah, I don't see it. So I'm just gonna start talking. Sorry, I won't be able to share this with you, but hopefully you can follow along. So this is stuff about the intestinal and rectal disorder PowerPoint. I was trying to find that to share it with you, but it looks like I just have an MP3 playing of that for some reason. I don't know what happened to the actual PowerPoint. So this is a really huge PowerPoint. So I'm going to go through a couple of things, and please just start chatting here if you have a question or you need me to say something else, okay? All right, so in this chapter, the first part of it talks about constipation, diarrhea in the beginning. So very simple kind of stuff, stuff that we all should know a little bit about. But I'm going to get into a couple things with that. This chapter is called Intestinal and Rectal Disorders. Okay, so the stuff with constipation. So typically, and if we were talking about this in class, I would say, what do you guys consider as constipation? And usually people will give me, varying things about how many days without having a bowel movement they think it might be. So we always want to say 3 days is our rule. So if someone has gone without having a bowel movement in 3 days, that's usually when you need to start giving them something to help them go. There's a ton of different reasons why someone might be constipated. Different medications can constipate you, immobility, fatigue, all kinds of things. So the things that I really want you to be concerned with constipation are the complications. So on this next slide, it talks about some of those complications. One of them is increased arterial pressure. So this is when someone strains to have a bowel movement. So this can cause a lot of problems when you strain. It can cause you to do the Valsalva maneuver, and you can pass out from this. I don't know if any of you have been working anywhere where you've seen this happen before. Now, what happens when you do this is this. So when you do this Valsalva maneuver, it makes your blood pressure go down, and it actually decreases blood flow to your chest. So this causes increased intrathoracic pressure. And then the pressure in your veins collapses in your chest. And this causes your heart to receive less blood. And so that's going to decrease your blood pressure. And then the thing with the Valsalva maneuver is your blood pressure will dramatically drop, and that's what makes you pass out. But then it rebounds and it goes up really high again. And when it does this, it could actually rupture, an artery or something when you do that. So you have to be very careful. So that's why someone should not try to strain to have a bowel movement. So you always, tell people, do not strain. If you're having an issue, let me give you something. The other things with complications would be fecal impaction. And I'm sure we've all seen someone like this before. So this would be where someone just doesn't have the strength to push out their bowel movement. So with this, sometimes you can like digitally get it out with your finger, which that would be a last resort. So what you would want to do first would be maybe give them an enema of some sort, because that's going to help loosen everything up and maybe get it out naturally. If you stick your finger up there, sometimes you can actually cause damage. So if you ever do have to do this, you only put it up a little ways and you just kind of go around the edges, and that usually will help, start to move things out. Fecal incontinence would be another complication. Hemorrhoids, we all know what hemorrhoids are, right? So these develop because of anal or vascular congestion caused by straining. So another reason why you shouldn't strain. Fissures. Do you guys know what a fissure is?
It's like a bloody, not a vein. It's like openings up.
So a fissure is like if you're straining to get something out, again, you can cause like cracking and stuff that happens around your anus. I kind of would describe this like when you're getting ready to have a baby and sometimes you're pushing so hard to get the baby out, sometimes you tear and things. That's kind of what fissures are, except you're not trying to have a baby, you're trying to have a bowel movement. Then we have rectal prolapse. That's another thing that could happen. So a lot of older adults get this, and you'll sometimes see an older adult as they go to the bathroom and they go to sit down and something falls out and you're like, what the heck is this? And here it's the rectum that fell out. So this is when part of the rectum slides out of place and sometimes it sticks out of the anus. So that's definitely not something you want to see. And then megacolon is another thing. So megacolon means that you have a dilated atonic colon. Atonic means that it doesn't have a lot of tone to it. So this is usually caused by a fecal mass that obstructs passage of colon contents. This person just doesn't have muscle tone to get this stuff out, so that's why this is happening. So if you have megacolon, then it's almost like you have a bowel obstruction, really, and so everything's just kind of sitting there, and as things keep going through your system, it keeps stopping right there, and it's going to keep building up until eventually that could burst and you could have a big problem. So symptoms of this would be constipation. Sometimes people will have liquid fecal incontinence, abdominal distension. And again, your biggest worry would be like after that build up so much that the pressure would just cause it to burst, and then you would end up having a perforated bowel and peritonitis. Okay, some other things, older adults always have an issue with, constipation. So there's some things that we talked about in here about that. So we should always try and get them to have more fiber in their diet, to be a little bit more active, because the more active they are, that's going to help. Prolonged bed rest is not good. So if you can get them up and moving, that's way better. And then to try and get them to drink a little bit more too, that always helps. So as far as treatment, you want to treat the underlying cause of the constipation. And then again, some other things that you could do, biofeedback mechanisms sometimes will help. Education about their bowels, exercise, bowel habit training, that kind of stuff would help. Laxatives. And then when this gets into diarrhea, it's talking about, again, diarrhea probably isn't as common as the constipation is with everyone, but this can be really uncomfortable for people when they have this. So it's when you have lots of frequent bowel movements, more than 3 per day, with altered consistency. So this means that I have quite a few bowel movements, but they're very loose. So that's your cue that it's diarrhea. Now, when someone has this, if they call out to you and ask you to give them something for this, you definitely have to see what the problem is. You need to first diagnose if they really do have it, and like how much are they actually having. And then when you would call, sometimes your physician won't give you something to give them right away to stop them up. Usually they want you to get a specimen and send that off for testing to see if maybe it's a different problem causing it. Because a lot of times you're worried about C. diff, right? So you would definitely have to get a specimen. And then once you get that, then maybe they'll be more apt to giving you something to stop them up. So with management and treatment of this, some of the medications you would give, you know, Imodium, kaopectate, Pepto-Bismol, all of these things have, you know, different complications that come with them. So you need to kind of be aware of some of those complications. All right, then we talk about fecal incontinence. So this is not something that's super common with everyone, but you do see it occasionally. So this is usually where I would get out the fecal management system to show you that we have at the school, but since we don't have it here, I can't show you. But generally this fecal management system it looks like a Foley basically, but you put it into the rectum, and this would only be used for someone who has liquid stools. So like say you had a patient who, you know, had a horrible wound on their coccyx or something, and you had to try and treat that. It would be really hard to treat that and keep your dressings clean and dry if you have someone that's constantly having diarrhea. So if you put this fecal management system in, it might actually help you be able to heal up that wound without getting all of that stool in there. So again, the fecal management system is something that you'll probably see eventually in your practice as a nurse. You put it in the same way as you would a Foley, except it goes into their rectum, and the balloon that you blow up would be a little bit larger than it would be if you were just doing a Foley. All right, so that's the first part of that. I'm just going to talk about a couple more things and then I'll actually get off here because I don't want to overload you with too much today. Okay, irritable bowel syndrome is another thing that's in this chapter. So I don't know if you guys know anyone who has this or not, but this can be really uncomfortable for people. This is a term used to describe a type of digestive disorder that's characterized by a group of common symptoms. So that's kind of hard to diagnose because you think that maybe there might be something else wrong. You probably rule out a ton of other things before you finally just say it's irritable bowel syndrome. So IBS affects more than 10% of the world's population, and although it can affect anyone, it's most common among young, middle-aged women. Twice as many women as men have it, especially those under 50. So with this, typically you're going to have like a change in your bowel habits. There's like no test really out there that can say, oh yes, you have irritable bowel syndrome. So from a doctor's standpoint, it's diagnosed, you know, from their symptoms. So usually their symptoms are going to be that they have a change in their bowel movements, whether it's, you know, lots of diarrhea or lots of constipation. Usually that consistency of their stool is going to be the big thing. Other things that go along with it. You would also have stomach bloating, gas, abdominal pain, nausea. You would easily feel full or have a loss of appetite. And then like the appearance of your stools are going to look different too. So the texture and color of them are going to be different. So typically when people have this, it's usually because of some type of food sensitivity that they have or an allergy. That's a lot of times that's what the problem is with this. Sometimes it's because of chronic stress. Other times it could be from traveling, like say you were out of the country and you're just off of your normal schedule, so maybe that caused it. And then also maybe your circadian rhythm is off, like, you know, maybe you went from one time zone to the next and you just are all off your normal schedule. And then sometimes it's hormonal imbalances too that can cause it, which a lot of us women have a lot of hormone problems sometimes. So with treatment for IBS then, you would try to avoid things that trigger you or figure out what your triggers are so you can avoid it. That would be your biggest thing. You want to reduce your stress as much as you can, get some regular exercise. A lot of times people will take probiotics to get them a little bit more regular. I don't know, you know how that Activia is very common with people anymore. So probiotics just add good bacteria back into your system, so that might, you know, help you if you had IBS. And then there's a certain type of diet, and this is not going to be on your test, this is just an FYI. It's called a low FODMAP diet. So FODMAP, low FODMAP diet. So this just reduces certain foods that contain carbohydrates that are hard to digest that might be causing some of your problems. So some of those things would be things like apples, artichokes, dairy products, wheat and rye, candy and gum with sweeteners, anything like that. In your ATI book, if you're looking at stuff about IBS, they mention two different medications. There's one called Lotrinex and one called Amitiza. These are specific medications just for women only who have IBS that would be kind of maybe a last resort. You know, maybe you try and do some of these things yourself to treat it, but then if you're still having lots of problems, maybe they would put you on one of these medications. Now, the Lotrinex is for IBS when you have diarrhea. The Amitiza is for IBS if you have constipation. So when you look at those in your ATI book, it'll tell you that one of the side effects of both of those would be going too far the opposite direction. So if I'm taking Lotrinex for diarrhea, then one of my side effects is going to be constipation. And then if I'm taking Amitiza for constipation, one of my side effects might be diarrhea. So anyway, you can kind of look at those a little bit in your ATI book to get familiar with those. All right, and then this gets into a little bit about celiac disease. So let me just tell you about celiac a little bit, and then we'll see if we want to do anything else from there. Okay, so celiac disease. So I used to have a girl that I worked with that ended up getting this, and she didn't know this is what she had, and she was having all kinds of problems and going under all of these different testing procedures to figure out what it was, and it ended up being this. So what it is it's an autoimmune disorder that can occur in genetically predisposed people. So this is where when you take in gluten, it leads to damage of your small intestine. So this affects a ton of people worldwide, more than you would think. It says 1 in 100 people have this. And again, it's hereditary, so it runs in your family. So people with a first-degree relative with this have a 1 in 10 risk of developing celiac disease. I wish I could show you this PowerPoint because it's kind of interesting. So inside your small intestine, we have something called villi, V-I-L-L-I. So these villi are like these finger-like projections inside your small intestine that kind of move a little bit to help move things through your small intestine. So when people have celiac disease, it affects your small intestine so much that these finger-like projections aren't big and long anymore. They become really short, like little nubs. And so this causes people to not be able to absorb things as well because of this. Okay, so in order to diagnose this, there are some blood tests that they could do, but there also is an endoscopy that they could do where they would take a biopsy of your small intestine and they could figure it out from there too. Now, again, what you would do for celiac disease, you're not going to fix your small intestine damage that's done. So what you have to do is just stay away from gluten, which is very difficult. But there's a ton of things out there that are gluten-free anymore. So yeah, so a lot of stuff has gluten in it, and you'd be unaware sometimes of how much things do have gluten in them. One of my former students was saying that her mother had a gluten allergy, and she lived with her mom, and her mom started to have some kind of reaction one day, and they thought, well, what the heck? We don't give her gluten anymore. What's going on? And here, there was gluten in the dog food, and she was handling the dog food when she was, putting it in the dog dish, and it just, got into her system and caused her to have issues. So you never know. There's a ton of things that have gluten in them, so you just have to totally stay away from it altogether to help yourself out. Okay, you guys, wish I could get you to be able to talk. Can you hear me still?
Yeah, can you hear us?
I can hear you now.
Hey.
Yes. Can you hear
Perfect.
me?
Yes.
Okay.
All right. So you guys heard what I just said, correct?
Yes.
Okay. I meant the whole thing.
Oh, yeah.
Yeah,
Okay.
we've been here the whole time.
Okay. I just want to make sure I wasn't just talking all this time without people hearing me. Okay. So I'm going to stop right there, so we're not overdoing it with how much we're talking about today. And then next time we talk about this stuff, I'll go over the rest. So again, my plan is Tuesday when we meet is going to be a review day for test 2. When you're thinking about test 2, the stuff that's going to be on there would be all of the fluid and electrolyte stuff. So this would include anything about IVs, anything about central lines, anything about TPN or tube feeds, all the different electrolyte abnormalities. So, your sodium, potassium, calcium, phosphorus, all of that. Trying to think what else. A little bit about acid base. So you need to know some of that acid base imbalance stuff. And then after all of that, that's all in chapter 13 of your big book. And then we do go over a little bit of GI stuff in this. And so when you're looking at your GI chapters, let me find it here. This would be chapter 43, 44, 45, 46. That would be what's going to be on test 2. Now, so when you look at test 2, like the first part of test 2 is going to be fluid and electrolyte, acid base, stuff about IVs, all of that. That's the first half of the test. And then the second half of the test is GI, everything. So the GI stuff that I focus on test 2 would be more like, your GERD and your gastritis and your peptic ulcer disease, that type of stuff. A little bit about some other things too, but that's the majority of it. So that's kind of how you need to look at test 2. Make sure that the stuff that I have posted on Canvas as far as videos and stuff you're looking at, just to make sure you're doing well with that. Tressa, you're asking about remediation.
Yes, ma'am.
Is this for test 1 or?
Yes, ma'am.
Okay. We can meet individually for that if you want.
Okay.
That's no problem. We can figure out what time or when,
Okay.
and I can even do it over the weekend if you need me to.
Sure. That's good. Thank you.
Okay. Any other questions about anything?
So you would
Sure.
rather do individual, or you don't do group remediation?
I mean, I can do small groups. I don't want to do a huge bunch of you.
Right. And you still have to put the grades in for the math, right? Or did you already?
Oh, for the math on the test? I think it's already
Yeah.
in.
Okay.
Normally, if it was a test I was giving you, normally at school, I would have to add that in. But I think because it's on a computer here, it already added everything in.
And it says 50 points only. Isn't it's 150, right?
Yeah, yeah. So I can mess with that. So don't worry about that.
Okay. All right.
Yeah, Ashley, I'm glad you asked that because I was wondering the same thing because they're listed as quizzes and they're only 50 points.
Yeah.
I can fix that.
I mean, you don't have to. No.
Well, I think you're going to want me to, honestly. No, I haven't really, honestly, I haven't like sat and looked at everyone's test yet. So I want to make sure I look through them and make sure there's nothing wrong that I need to fix or anything. So just kind of sit tight with that.
Okay. And this is we're about our care plan. So, how I say it, there's definitely enough information to put on a care plan that you gave us, correct?
Yeah, this
Like,
is
should we have more?
this is totally not like what you normally would be doing, because what you normally
Okay.
would be doing would be a huge big care plan, right? So
Yeah.
you take whatever I gave you in that scenario, and that's what you're using for this. So remember, there's a different template for this compared to what you normally would be using too. So on that
Mhm.
template, like when it says assessment, there's not much assessment information in there, right? So you only use what would be
Right.
appropriate for whatever diagnosis you choose. So like say you're using, which I don't even remember what I put in my scenario, but like say you're using, I don't know, I'm trying to think of a diagnosis. Say you're using impaired nutrition less than body requirements. So
Mhm.
if I said in the scenario that this person had a weight loss of 10 pounds or something in the last couple weeks, then that would be significant. You would put that in your assessment right there. If you were doing something about pain or something about, well, let's say just say pain. So you would put pain level in there for your assessment. You might even put their vital signs in there because that would, talk to that,
Okay. So just basically put whatever diagnosis you're doing, make sure the assessment lines up.
Yeah.
Okay.
And Miss Silk, I have a question.
Yeah.
I went back to the exam we took today, and yeah, it says questions 49 and 50 not graded yet for
Okay.
those two questions.
I'll look at it. Don't worry about it.
Okay.
Miss Silk, can I ask one more question?
Yeah.
On the care plan where it says subjective, when the patient comes in, the patient is pretty much confused. So can we put, like the wife says, in quotation marks, that the husband has been drinking, I think it was a 6-pack per day. Can we put that in the subjective part?
Yeah. Anything that someone says is subjective information. So yeah.
Okay. Okay. Thank you.
Uh-huh. Anything else?
Sorry your day was kind of busy. Hope you have a good weekend at least.
Oh, thanks. I know it's just crazy anymore. I feel like all I do is get up in the morning and I'm on here all day until really late. And then I get off of here and then I get up and do the same thing.
At least you don't have to get dressed.
Yeah, but it stinks. So hopefully it'll get better. But
All right. Have a good day. Thank you so much for today.
all right. We'll see you guys later.
All right.
Thank you
Thank
so
you.
much.
Uh-huh.